education session here. Just wanted to make another plug for our IAPIC board positions that we have available. We have some board member positions as well as our secretary and president-elect position. So I just want to kind of put a plug out there for everyone, and then also we'll if you are interested, just get in contact with me. My name's Trent, and I'm the president-elect for this year, and I'll be stepping into the president position next year. So if you have any questions, you can reach out to me, and I can kind of get you some more information on that. So with that, I will turn it over to Tatiana to introduce our speaker for today.
Thank you, Trent. We're so happy to have this opportunity to have Jim Gauthier talk to us today and present on new organisms in healthcare. So a little bit about him is Jim is a medical laboratory technologist by training and worked in a hospital microbiology labs for 19 years. He first became board certified in 1990, so about 30 years ago, and has worked in or consulted to acute care, non-acute care, including behavioral health clinics such as medical, dental, and optometry, schools for students, teachers, and custodial staff, and industry, and even the funeral industry. Jim joined Diversity in 2015 as their senior clinical advisor in infection prevention, and he lives just outside of Kingston, Ontario. He has delivered lectures and trainings at many conferences throughout the world, including England, Germany, Austria, Croatia, Malta, Portugal, France, and New Zealand. So we are very glad for this opportunity to have you here today. And Jim, we'll turn the mic to you. Thank you.
Thank you very much, Tati. I appreciate the introduction. I sound like an awfully busy guy, but I've still got the best job in the world because I get to do this, talk to people and share information and try to calm your panic. I'm hoping when we have these new organisms show up. So I have to do a full disclosure here. As Tati said, I am employed by Diversity. They have very little input into anything that I do, which is why I have the best job in the world. They basically let me have free reign to educate, whether it is a customer or a non-customer. I'm here to act as the infection preventionist for the company. There's actually two of us. Carol Calabrese is my partner in crime in all of this. But that's, this presentation, I'm not sure, other than some sales reps that have been online, have actually seen this presentation. So what I want to do is talk about a little bit about how frequently we see new organisms show up in our healthcare world. And I always look at a new bug by how does a disinfectant react against it? Even if before I got into this role, I had to know, is it hard to kill or easy to kill in our healthcare environment? And I'm also old enough that I went through the original SARS back in 2003. So yeah, 30 years experience in infection prevention and control, but I was frontline SARS back in 2003, and I was only 2.5 hours from the epicenter in Canada. So I learned a lot about how to answer questions and how to calm panic around these new organisms, because there's always going to be new organisms. If we look at who our bugs are, the Diversity actually got me to look at the bugs in much more of a categorical effect or buckets. So I always look at when something shows up, a new microorganism, is it a bacteria? And is it gram-negative or gram-positive? Does the bacteria have spores? Because then that's an issue in terms of how we kill it. So if we have a new version of, say, Clostridioides difficile show up, when there is worries about Bacillus anthracis being used as a weapon of bioterrorism, that changes things because it has the spore. When viruses show up, I always have to know whether they're enveloped or non-enveloped, and I'll talk about that in a second, or if the new pathogen is a fungi, especially with things like Candida auris. I put them into these buckets. It's easier to talk about. When I lecture on basic microbiology, I usually go through this kind of a format. I just did a presentation last week on what we call the Dirty Dozen, which is sort of the top 12 or 13 microorganisms that show up. And again, I follow this kind of a format with them. So, we've had lots of enemies. Staph aureus, as you're well aware of, with its resistant form. Are gram-negative rods like E. coli and Klebsiella and their resistant forms, and I'll talk about those also. The enterococci that developed vancomycin resistance. Clostridium species and Clostridioides species have been around for quite a while. Our envelope viruses, they're ones that seem to cause a lot of panic. And I'm glad, really, deep down, that when we have a pandemic, we actually had a virus show up that is easy to kill, because the coronavirus falls into this enveloped virus category. If it had been a non-enveloped virus, they're not easy to kill. And you can see how I remember that myself, that non-enveloped, they're not easy to kill. And I've listed a couple here that give us problems throughout healthcare. And I'm watching right now where I'm sitting. I think we've got 12 daycares in my health region that have respiratory outbreaks that seem to all be rhinovirus. The SARS-CoV-2 is not showing up in these places where the children are kept, but the rhinovirus is a little more scary because it's not easy to kill. So large non-envelope viruses like rotavirus and adenovirus are actually a little easier to kill than even those non-envelope viruses. So that's what I look at when somebody says to me, Jim, we just had an outbreak of, and insert the virus name. I hate to say it, but the first place I go is Wikipedia, because I have to find out if it's enveloped or non-enveloped. And if it's non-enveloped, is it large or small? And the dividing line on that's about 40 nanometers. But and fungi, we've always had fungi around. We've had candida causing problems in our immunosuppressed people for a long time. And then we've got the fungi, aspergillus, that shows up when we have something going on with construction, and then our regular run-of-the-mill skin fungal infections that are listed here. So the new enemies that I've been through, unfortunately, in my 30-some-odd years, SARS-CoV-1 is mentioned in 2003. Then we had the pandemic H1N1 influenza A in 2009. Weirdly enough, I remember exactly where I was when that broke. MERS-CoV-2, which is the Middle East Respiratory Syndrome coronavirus that's been showing up in the Arabian Peninsula since about 2012. Ebola, I was just updating a document on that today, that has caused its issues and concerns, and it killed well over, or darn close to 11,500 people in the big outbreak there in 2014 to 2016, when we all did our planning for Ebola coming to our shores. We had Zika show up in Brazil, causing issues with the microcephaly. It was how it was being recognized. It's not a new virus, but it was causing issues. Elizabeth Kingia Anopheles popped up out of nowhere in sort of the middle of the continent. Gram-negative rot, first thing I looked at, so I knew the disinfectants that I could use against it, and it disappeared again. We never did quite figure out where that one came from. Candida auris, the new fungi, and I've got a slide on that. And of course, the United States has still got an ongoing hepatitis A outbreak in some of its states that the CDC updates us on, not quite as frequently more recently. And then obviously SARS-CoV-2. I'm sure you're all familiar with this. I put this slide in sort of as a placeholder that the illness is a contraction of coronavirus disease 2019. We know it's got good human-to-human spread. It does appear to be mainly droplet. There is some contact transmission, as there would be for any respiratory virus. If you don't subscribe to ProMed, please do. It's listed there, free update. You get a digest of infectious diseases around the world. And then I always have my worldometer on just to be depressed every 3 to 4 hours when I update what's happening worldwide with cases of coronavirus. So the pandemic was declared on March 11th. I've got some statistics here. You can see these are the United States statistics that I do this presentation fairly regularly, and I update it. As of today, you're at 7.19 million cases. You're just around 205,000 deaths, according to Worldometer, which is a death rate of 2.89. That's just a gross, dividing the 205 by 7.1 mil. But the death rate per million population, I watch to see what's actually going on, because that balances it out around the world. So as of just before lunch today, the U.S. death rate per million population was 626, compared to my country's death rate of 245. Canada still hasn't hit 150,000 cases, yet my Quebec province right next door to Ontario has just shut down public gatherings again because our numbers are up. We're only seeing 1,200 cases a day, but we're not going to let this get out of control up here. So there's things that are happening, and the panic is obviously there. I got this definition from dictionary.com: a sudden overwhelming fear with or without cause that produces hysterical or irrational behavior that often spreads quickly through a group of persons or animals. Now, I'm not talking about the psychological panic that people face, and I'm not trying to downplay that at all. My daughter suffers from a little bit of an anxiety disorder, so I fully appreciate that some people can't control this. What I'm talking about is when somebody says a new bug and everybody freaks out. Because that's what we all live with as infection preventionists. And you will see different things happening, different images coming up. People want to hit the panic button. We all have that temptation at this point in time to start pulling our hair out as our cases start to go up again. So even the Bible had a quote that I found. I'm not sure how I found this, but my heart is in anguish within me. The terrors of death have fallen on me. Fear and trembling have beset me. Horror has overwhelmed me. And that's what we have experienced with all of those bugs I mentioned, from SARS, the original, through to where we are sitting right now. So when this first started, I was doing this presentation actually in Memphis, Tennessee, back around March 9th, because it was just before all my traveling got canceled. And I had to insert this slide as to what was going on, because I'd never expected it back in March to get this bad. So we were canceling our sporting events. All the professional sports got shut down. We were doing our quarantining that came in. Nobody could find toilet paper, which I still haven't figured out. Costco stopped issuing samples, and I'm not sure how they expected me to feed myself when I'm shopping. If you put in COVID panic into Google, when I did it, whenever this slide is from, there was 242 million hits on the panic issue that's going on with this. Then we've had the confusion as to what's going on with this virus that doesn't help us as infection preventionists or even EVS staff, when originally we were saying, well, no, you don't really need to have a mask out in public, because most respiratory viruses, you're only contagious if you're symptomatic. And that's what we saw with SARS, the original. We know with influenza that you have the prodromal period of about 24 hours where people will excrete virus before they become symptomatic. With SARS-CoV-2, we recognize there is an actual asymptomatic state where you have the virus in your respiratory secretions. You may not ever be ill. And that's where the change came from. And I've had to explain this to people. It's not that we're making this up. We are going on information as it becomes available. And then we got into this whole, what is droplet and what is airborne? What is the definition of airborne? What do we need to do around airborne generating procedures? And I'm going to come back to that because it sort of freaks me out. So some of the other panic we saw, I found this as a quote from Mel Robbins around fear-bola. And I'll read this. It's a hypercontagious disease that affects the brain, making sufferers fear a widespread Ebola outbreak in the United States. Fear-bola is an airborne disease that spreads through conversation, entering your brain through your ears. Fear-bola is so contagious that some victims have contracted it simply by seeing images and videos about Ebola. Now, I don't know if this happened up in Idaho, but I'm sure in larger city centers, people were going into emergency rooms saying they had Ebola because of this. Now, in real time here, we've gone to the other end of the pendulum where we have people saying COVID is a hoax and it's not really there and it's just people trying to get money or something ridiculous. I keep posting stuff on my own social media about the long-term problems of this virus. Trying to establish a little bit more fear, but at the same time not shut down the world. Because as I stated, I went through the original SARS, and ProMed was that news update that back in November, December of 2002, they were talking about this atypical pneumonia that was showing up in the Guangdong province of China. And then it got into Hong Kong. Somebody got an airplane and came to Toronto and went to an emergency room. And that was the start of it. Worldwide, we actually only had 8,900 cases. The death rate was about 9% with it. We did manage to shut it down, and there's a whole bunch of reasons around that I'm not going to get into. But at the time, in 2003, we shut every door into our hospital in Kingston, which turned out to be 46 different entrances into the complex. And we shut it down to one door that you all had to line up and come in and say you didn't have a fever or a cough. So you can see the nurse there that's doing the screening, Buddy standing behind her that has absolutely no mask on. We're not doing social distancing because at the time you had to be symptomatic to spit this virus out. So as long as you were not coughing and didn't have a fever, you could come in. So the social distancing is also a new concept for us around getting into that 6 feet or 2 meter distance. So I spent a lot of time with that one trying to say to people, don't panic, because what I was seeing with the spread of the virus in China and Hong Kong, at that time, it was still Hong Kong. But what I was seeing was droplet spread. So I kept saying to people, don't get coughed on. Calm down. Just don't get coughed on. Wear your face protection. And I learned that by just my experience of being a microbiology technologist. Yes, that's me in grade 10 when I had hair. I think I do have, I'm not sure if I have a picture. Oh, I do have a picture in here of me currently. So, penicillin resistance came out and we all thought the world was going to end. Staph aureus is a great pathogen. If you got it in your bloodstream before 1940, 80% of you died. It's a phenomenal pathogen. It's got that ability of hiding itself in you. So it wraps your own plasma around itself with its coagulase enzyme. We got penicillin that came out in 38. Resistance was being seen within 4 years. Nowadays, it's 95% resistant, all Staph aureus. And when I was in the laboratory, you never saw a staph that was sensitive to penicillin. And so what we did is we knew what the penicillin molecule looked like. We knew it had this beta-lactam ring in it. So we took that basic structure, had our organic chemists say, okay, can you make a semi-synthetic penicillin? They said, sure. We'll change some of the side rings on it, and they came up with methicillin, a semi-synthetic penicillin. We also developed cloxacillin, released it in 1961, resistance by 1962, and the spread just went through Europe. First recorded case in the United States, believe it or not, was 1968. Canada, we managed to hold it at the border for a while until 1981, and it actually sort of snuck in the back door. It came to us from a Canadian returning from India where they had been in a motor vehicle accident, found in a clinical specimen. The infection preventionist, who I subsequently learned, she was my mentor, did a point prevalence of the hospital. It was 1,100 bed hospital, and they found this bug 2 floors up, 1 floor down, and needless to say, everybody panicked. Me as a microbiology tech kept just sort of going, but it's still just a staph bug. And then it showed up in my hometown, Nelson, British Columbia, just north of where you were sitting in the southern interior of British Columbia. Showed up around the mid-90s. I was the microbiology supervisor, but also the infection preventionist, and it was the same. Everybody freaked out, and I kept having to walk around going, it's a staph bug. Wash your hands. Disinfect the environment. The basics of what we had. I was also in the laboratory when HIV first showed up. And that was watching young men who had sex with men come down with old man diseases, like Kaposi sarcoma you don't see in young, healthy men. Then they all started developing this atypical pneumonia caused by pneumocystis carinii. So this was reported, and we sort of got a hold as to what was happening here. And the panic around this virus in the LGBTQ community, I still shudder when I talk about. I had a lot of friends that were part of this community. The issues that went through it, the information they tried to get out there, children that received the HIV virus through blood transfusions that were being shunned and socially ostracized was just not a good part of our history. We had healthcare workers who refused to provide care. I had one of my virologist friends who was also an infection preventionist. He was a medical doctor. Have to go up to nurses in a pediatric unit where they had pediatric patients with HIV and really read them the riot act about working with these patients and explain graphically how they would get what they had to do to get the virus. And basically saying, if you got the virus from one of these children, you're going to be arrested because you've done something you shouldn't be doing. But then we had our first responders, EMS, firefighters, police, wanting a national list in Canada of all known HIV positive people and their address, so that when they got called out to 123 Park Street in my town of Kingston, they could look it up to see if the person had HIV. What came out of that, though, was it led to universal precautions and then body substance precautions as it morphed, and then it developed into standard precautions. Where, Canada, we took your standard precautions and marked on it with a crayon and called it routine practices and additional precautions. But it led to a lot of good things where we treat everyone as though they're potentially infectious to us. And we also, out of all of this came our safety needles. It is very difficult now to stab yourself in healthcare, thank goodness. And that all is from looking at what was going on with HIV. So it helped with that panic. VRE, vancomycin-resistant enterococci, showed up in 86. There was a good paper on it in 1988. Probably selected for by overuse of vancomycin and ceftazidime, because we used to use that for febrile neutropenics. Just bam, you have a fever, you're neutropenic, you give vancomycin and ceftazidime. Especially Eastern Seaboard, New York. This was a huge issue there, but it spread rapidly because the VRE are part of everyone's normal flora. We all carry it in, not VRE, but the enterococci we carry in our gut. The big fear around this was that resistance mechanism would get into group A strep, because genetically they're very similar. And actually the enterococci used to be part of the streptococci group. And we've never seen that. We still got pretty much a pan-resistant group A strep. So that panic never went anywhere. And I'm not sure what you do in your locale. Here in Kingston, our acute care hospital stopped isolating for it. We don't even culture for it if you've transferred us from anywhere. And if you're found to be positive, we still use our standard precautions. So that's being discussed throughout our province as to whether that's good or not. I'm not going to recommend one way or the other. Clostridium difficile, we knew it in the culture in 1935. 1974, it was linked to causing pseudomembranous colitis. We know it has these toxins now that cause the issues. Our panic around this is because of the spore. And a lot of weird things go on in different parts of the world because of the spore. And I actually did a presentation on do you need to use a sporicide everywhere? And the link to that is in the resources. If you have a spare 45 minutes, I'll try to convince you not to use a sporicide everywhere. And yes, as you notice at the top, the name has changed. I only heard about it about a year ago now, but it was actually in 2016 that the microbiology guys do what the microbiology guys do and change the name to Clostridioides difficile. It is the only genus and species at this point. So there's only one Clostridioides species. The Clostridium species still does exist. I think I have a slide on that coming up too. So we track it. C. difficile has a lot of mortality to it. It has tons of morbidity. It makes people unwell. The AHQR site hasn't been updated since 2009 that I could find. In Ontario, this is a reportable disease. Every month, you have to submit your numbers based on rate per 1,000 patient days. I love my government here. They let you know that you want the graph to be low on the right-hand side. That's good. And I've seen that in other people's graphs for sure. But we trundle along at around 2.8 cases, or sorry, 0.28 cases per 1,000 or 2.8 cases per 10,000 in our province. It doesn't change much considering all the stuff we have put in place. This is sort of an endemic rate in the background for this province, but you can't hide. And that's the reason we had to start reporting it. Is we had some hospitals that had horrific outbreaks that went on, and until it hit the media, there were some issues with that. So our government said, enough of that. You now have to report it. We also have to report ventilator-associated events, bloodstream infections with MRSA and VRE, and annually we have to report our hand hygiene rates by hospital on our public access websites. Gram-negative resistance causes panic. Again, the appearance of an extended spectrum beta-lactamase beyond the regular run-of-the-mill beta-lactamase that breaks down that beta-lactam ring. It changed, and every time we come up with something to get around that, the organisms modify themselves. Now we've discovered this carbapenemase that attacks the carbapenem antibiotics. And we get into our acronym madness of CPE being carbapenemase producing Enterobacteriaceae, CRE is a carbapenem-resistant Enterobacteriaceae, but they may not have the enzyme. There are some Enterobacteriaceae, that whole family, that are just intrinsically resistant. It's not really an enzyme that does it. So I was at a presentation where they talked about CPCRE, which is carbapenemase producing carbapenem-resistant Enterobacteriaceae, because those bugs generally have the plasmid that can move that resistance to other species and genera. So that's the one they worry about a lot more. Not just a run-of-the-mill Proteus that's resistant to carbapenem. It may not be the enzyme, but if it has that carbapenemase enzyme, that's a little bit more worrying. Parts of my country call them all CPO, carbapenemase producing organisms. But we get that confusion that goes on with it. Candida auris, another bug. I'm not going to spend a ton of time on this. We're quite well versed in it. It seems to be flaring up a little bit in many parts of the United States, which I'm not quite sure, considering everyone is very attuned to what we should be doing with every patient. But it's now being found everywhere. We're seeing outbreaks that go on. We have good guidance coming from the CDC on this. And again, Carol Calabrese and I did another presentation on this just as an update. It's probably a little dated now in terms of what's going on. So what am I trying to indicate here? There's always going to be new organisms. And what I always want people to focus on is horizontal infection control, not vertical. And the way you will see the difference between these two is this diagram. So vertical infection control is the circle under the Staph aureus, where we worry about MRSA, and we get focused on a single pathogen or anatomic site. So you all know we've got documents on MRSA. We've got documents from the CDC on VRE, ESBLs, CRE, Acinetobacter, Candida auris. A new bug shows up, you get a new document from the CDC, I get one from the Public Health Agency of Canada, World Health Organization issues theirs, and off we go. But we focus on that one bug. Whereas horizontal infection control looks at the 4 organisms across here as an example. We worry about all infections for all pathogens. So horizontal infection control is having a robust hand hygiene program in place that is audited and things are fed back because we know that works. We have a very good decolonization therapy in place in terms of chlorhexidine bathing for certain intensive care unit patients. We do our nasal decolonization therapies now for certain surgical procedures. We have our antibiotic stewardship programs. The Board to Ward is a British program that you can read about where They finally said to the CEOs, you have to get your rates down. And it was mainly around Clostridioides difficile. But they put the onus on the board. So your chief executive officer and your chief operating officer and your chief medical officer had to be seen on the wards and taking part in all of these programs for all bugs. It was mainly because of C. difficile, but they saw all of their healthcare associated infections drop. Some of that is from a good, robust antibiotic stewardship program. And I've got a presentation on, it's called the Healthcare Associated Infection Equation. Are you covering all the angles? And I look at all of these as an equation and what can go into causing an HAI. And having a robust antibiotic stewardship program offers a lot. And then having very standardized cleaning and disinfection, not focusing on one bug. And when we start to go vertical, we run into a lot of issues. I was sitting in Vancouver, British Columbia, Canada, at a conference, and somebody asked a question of, can somebody explain the difference to me of enhanced contact precautions versus contact plus? I'm thinking, what's wrong with contact? And it turned out enhanced contact precautions was for C. difficile, where they used the sporicide in the room. And I said, okay, I can sort of live with that, unless you listen to my talk on do you need a sporicide everywhere. And contact plus was for the CRE, the carbapenem organisms, where they actually assign the nurse because they're having a heck of a time. It's in their sink drains, but it got confusing for everybody what was going on. It's the same as having contact airborne, droplet sort of sideways. I don't know. I like doing this presentation when I can actually see you all, because I want to see a show of hands for how many of you remove alcohol-based hand rub from a patient's room that has C. difficile and force the staff to use soap and water, because alcohol doesn't kill spores. And I keep going, but if you have gloves on for contact precautions and your gloves aren't fecally soiled, you should just be able to use ABHR. You don't need soap and water if you haven't had any contact with the feces. Whereas for any patient, horizontally, for any patient, if you come away from a patient encounter and your gloves are grossly soiled with feces, you should wash your hands, full stop. That's the way I look at this. But I know there's many healthcare systems, there's many states that say, if you have a patient with Clostridioides difficile, you cannot use alcohol-based hand rub. And I'm thinking, well, no, that's a little dangerous. Let's go back to how fecally soiled was the healthcare provider and how well are you cleaning the environment? Because that gets it more horizontal to me. So when I get handled or asked a question, I try not to do the shrug. I find that doesn't work very well, saying, no freaking idea, see ya. I will ponder issues and think about it. I might scratch my head. But many people look at us, there I am. Many people look at us as the super resource person. We're the ones they come to when they have these kind of questions. And I know some of us get branded with having the Superman logo on our chests. I always know what my limitations are. I've got a great microbiology background. When I was a frontline microbiology tech, my doctors treated me like a medical microbiologist or an infectious disease partner. And I knew when to say, call the ID doc. I knew my limitations. I knew where to look stuff up. So I could always say, I may not know right now, I know where to look it up. But it's important that we understand that. But when I got a question, I always use the chain of transmission or the chain of infection, where you have to have the infectious agent that lives and resides in the reservoir, that gets out of the reservoir through a portal of exit, and then through a mode of transmission gains entry to the portal of entry of the susceptible host. And I'm sure you are all well versed in lecturing that if you can break any one of these links, you don't end up with an infection. So with I'm going to talk both on the chain itself, but also putting in SARS-CoV-2. So the reservoir, we know SARS-CoV-2, the reservoir is the respiratory tract or a surface contaminated with respiratory secretions, full stop. Animals, right now, we know cats can get it. We're not seeing a lot of transmission from the animal to humans. The whole feline population, they're doing a bunch of culling in the Netherlands of minks. Apparently they harbor it quite well. They think they got it from us, but they're worried they're going to give it back. It's not in the food chain. The environment I've talked about, and this is more for the other pathogens that we worry about the reservoir, because some of them do utilize these parts. And we can break that link. If I cough into my hand and I've got SARS-CoV-2 in there, hand hygiene gets rid of the reservoir. I'm done. We do disinfect the environment for all of our pathogens. That's the cornerstone of why my company exists. We get rid of the skin flora reservoir when we have a patient going off to surgery, right? We use our preoperative skin prep, both them bathing at home or before surgery, we actually put down some sort of a skin antiseptic product for removing that skin flora. We're redesigning our sinks. You should see the new hospital we built up here in Kingston, where all of the sinks, the spout that drops the water onto your hands and the sink drain hole are offset from each other. And they're designed to minimize the amount of splashing that happens because we recognize sinks can be a reservoir. So the portal of exit, how do we get the bug out of there? Well, with SARS-CoV-2, this is well recognized. Coughing, sneezing, talking or singing loudly. And then these aerosol generating procedures that every time I turn around, somebody is making a new one up. And this is where I needed to rattle the cage of IAPIC and IAPIC Canada saying this is out of control. They tried to do this during SARS. We never showed it was spread by aerosols. The papers that talk about intubation, extubation, when you look back at those papers from 2012, where they looked at everyone, 2012 was a review paper that looked at all the papers that talked about healthcare workers that got SARS, the original. Problem was they didn't control for a whole bunch of things. So some people did get sick during intubation, but nobody noted what their hand hygiene was like, what the environmental disinfection was like, or did they have eye protection on, or if they even had a mask on. During SARS, the original, when I talked to the anesthesiologists, they all looked at me and said, "You don't expect me to put a surgical mask on to intubate a patient during a routine intubation. You know, I know the patient. It's an elective surgery. Why would I put a mask on to intubate?" That's where we were at in 2003. So people that got sick, we linked it to some things. Patients being on BiPAP. Yes, we spread it in Toronto, well recognized. We put somebody on BiPAP. They infected a whole bunch of people up to 3 meters away from them, 10 feet away. But again, we didn't control for, did they have any face protection on when you work with somebody on an assisted ventilation? We didn't control for that. So this got totally out of control. Then the dentist got hold of this. And I'm thinking, where the heck did that come from? Dentists always have a mask and eye protection on. Then the gastroenterologist started saying, well, when I do a colonoscopy, the patient passes gas afterwards, and that must be aerosol generating. So this has got a little out of control, and this will settle down once we get the pandemic under control. People are going to take another look at this. And I'll come back to that. Again, I can't leave it alone. So how do we break that portal of exit? We wear masks in case we have it in our respiratory secretions. Having something over your nose and mouth limits what is spit out in big droplets. Can virus get through a mask? Yes, we know that, but it still limits what's actually coming through. That's why we wear surgical masks in surgery, so that when we're talking to each other in a surgical suite, we're not spitting in the patient's wound. That's all it's trying to do, is catch the big drops. And we've always lectured, cover your coughs and sneezes, cough into your sleeve. When I was sitting in the airport doing a presentation just before everything got shut down, the number of people that walk through airports and just let rip with a cough or a sneeze appalls me, with not even having that concept of trying to limit how much spit comes out. Mode of transmission, how we move that pathogen from the reservoir to the new host. Well, if I have SARS-CoV-2 and kiss my wife who doesn't, that's direct contact. We share spit. So right now I'm recommending that you do not kiss anyone who is hot. And I mean temperature-wise, not good looking. Indirect contact, where you actually have the organism on a fomite. So I cough on my computer keyboard. The next healthcare worker sits down and uses the keyboard and touches the portal of entry. That's indirect transmission. So we know we can spread it and move it on equipment. It's not, we don't think it's moved as well as some other respiratory viruses because it is enveloped. We know it is being moved on hands for sure. In other organisms and stuff like that, we could spread it through sex for sure. Other modes of transmissions that has nothing to do with SARS-CoV-2, but normally I would talk about needle stick injury, percutaneous kind of exposure. This droplet thing, airborne, I sat through a 2-day virtual webinar on airborne transmission with a bunch of scientists that do a lot of study into airborne, and we all define it differently. My traditional definition is up here. Droplet is bigger than 5 microns. Airborne is less than 5 microns. That's based on what your respiratory tract can capture, the physiology of it. And there's a lot of discussion that larger particles, bigger than 5 microns, can travel farther than the 6 feet. I appreciate that. Is it enough virus to make someone sick? We don't know. There's just a paper published in JAMA Online that I read yesterday morning, because I get these updates in my personal email, and they were looking at finding SARS-CoV-2 in the environment, and they sampled the air of known positive patients who had a cough, and they never picked up the virus from the air. They did get it from all kinds of surfaces, and what they actually showed, if you just sprayed disinfectant in the room twice a day, there was still tons of virus present. If you used a disinfectant wipe and actually did the physical removal, they found no SARS-CoV-2 in the patient's room. So this was just published in JAMA. I'd have to look in my other screen here when we're done if I can find the URL, or I might actually send it because it was free and I can send that to Taddy. Other modes of transmission that we don't worry about with this virus, but it can happen in healthcare, is food, water, medication via the common vehicle. I have a whole presentation on what you can get by being bit. If you ever want to be really scared about going outside, have me back. And to break that link up, the direct and indirect is hand hygiene and environmental disinfection. You can see the commonalities here, and good use of personal protective equipment. SARS taught us anybody with a fever and a cough is potentially infectious. And in Ontario, anybody with a fever and a cough is on droplet contact precautions, full stop. We don't care what's causing your fever and cough. That's how we start. And then from there, we spread from other precautions that we might need. And we isolate infected patients. Now, we isolate some patients that aren't soiling the environment, which is a big discussion on MRSA, whether we need to do that or not. And then the main way that we should have been breaking this since I was a little tiny guy and a novice in infection prevention and control is you shouldn't go to work sick. You shouldn't go anywhere sick. But just the way some sick policies are, people have to show up and work unwell. How do we break the link around airborne droplet? Face protection. Post-SARS, the original, most of the studies showed that face protection was protective. A mask was protective. It didn't matter whether it was a surgical mask or an N95 respirator, a mask was protective. There's just a paper that also was published out of China where they noted that everyone on their SARS floor, I think it was like 70% of them didn't wear glasses. And they just made it as a comment that if it seemed to be the people that had glasses on didn't show up in their SARS floor. So they're wondering if that eye protection is there. I've got papers that show it was an RSV outbreak that when they finally put the staff added goggles or a face shield to the mask, none of the staff picked up RSV. So the eyes really do need to be protected. And then airflow. Do we really need airborne infection isolation rooms, negative pressure? Right now we're using it. I still think the jury is out on that. I personally don't think it's necessary, but you've got to follow your local state and federal guidelines on this. There's another picture of my fat little face. I need to squeeze that slide slightly. The portal of entry for this virus is your eye, nose, or mouth. And I keep saying this to people, you can have the virus on your hands, just don't touch your eyes, nose, or mouth until you sanitize your hands. That's the only way this virus gets into us. There are other portals of entry for sure, but for this virus, it's that T-zone. And I find this a very graphic picture to show people. You can take anyone's picture, use clip arts or whatever to put the T on top here. It's not hard to make. And so we want to protect our faces and our eyes. We have to cover the entire T-zone. The picture on the right with the teal covered masks there is what we use for every patient with a cough and fever in the province of Ontario since 2003. Now, they are in short demand right now. Every piece of PPE is. So we've gone to more of a face shield with surgical mask. This is what was protective and what we found through since SARS, through till we had this virus show up early this year, and everybody freaked out. This was protective to us. We had no trouble with this. We went to an N95 respirator with TB, don't get me wrong, and measles and those kind of wonderful things. But that mask was our standard mask to the point where if you walked into any patient room that had a cough and a fever, a box of those is sitting outside. I'm not trying to sell them. It's just what we use. Susceptible host is becoming better recognized. There's definite patient populations with SARS-CoV-2. The elderly have taken it on the chin. The last number I saw was 80% of our deaths in Canada were in long-term care facilities in the elderly. We know obese, high blood pressure, lung issues, any kind of diabetes, heart issues. We're seeing the multi-system inflammatory syndrome in children. I just downloaded 2 papers today on a genetic link that they think it seems to be higher in men, and it's some sort of a weird loci change thing. I haven't read them in detail yet, but it might explain why some 19-year-olds get this and die, and why some 96-year-olds get it and sort of go, ha, 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 I have a cold. I think, we're only 9 months, 10 months into this illness. We're still learning a lot. We're now starting to do the studies on when women got infected in their gestation period and what outcomes are coming from that. This is still a new virus. We're just starting to have women who were exposed at conception now delivering these children. So we still have a lot to learn. I keep reminding people. So I found by using the chain of transmission, it helps explain the risk and it calms some of the panic as to what's going on. And I've done that literally with healthcare workers, saying, if you wash your hands, you can't get sick. If you don't touch your eye, nose, or mouth, your portal of entry, you can't get sick. And a lot of times you see the disinfectants there. They have a variety of killability. A lot of disinfectant manufacturers, we had the EPA emerging viral pathogen language on all of our disinfectants when that document came out in 2016. And that allowed us right away to say, this is a new emerging envelope virus. We have a large non-envelope virus and a small non-envelope virus on our disinfectant label. So we should be able to kill this organism. Sometimes you have to use a surrogate marker. We can't grow human norovirus. So we have to use either the feline calicivirus or the murine calicivirus, the cat or the mouse norovirus, because we just don't have it. And we can't give you every organism under the sun. Please trust me, it takes anywhere from $10,000 to $30,000 per organism to put it on the label, which is a bunch of money. If you want to see 80 label claims instead of just 40, the disinfectant is going to be more expensive. I hate to say it. What also broke it, hand hygiene and good use of personal protective equipment. Knowing what the organism is when a new organism shows up, and it's going to, and classifying it into these buckets will help you answer the questions for sure. Because this is taken from Dr. Ritella's paper on the ideal disinfectant. This is a gradient from the easiest to kill, which are envelope viruses, which is coronavirus down there in the bottom right, up through gram-positive bacteria, large non-envelopes, vegetative fungi, which are yeasts, are gram-negative bacteria. So once you get up to that gram-negative bacteria in this place up in here, that is a hospital disinfectant. Where it starts to get a little weird is the fungicidal label claims, not that we have to kill fungi on surfaces. The small non-envelope viruses is what I think everyone should look for on their disinfectant. A lot of people look for the tuberculocidal label claim, especially those of us that have been around for a while, that remember the 1991 recommendation from OSHA that we use a tuberculocidal product against HIV. HIV way down there at the bottom. Everybody look down at the bottom, see HIV. To me, the tuberculocidal label claim causes a lot of surface breakdown with the different disinfectants because it's really hard to kill. To me, I would want to see 2 or 3 different small non-envelope viruses on a label. That means a lot more to me, especially if you can say to me, I can kill both norovirus, the murine and the feline, and say hepatitis A, because I know that's really hard to kill too. The sporicidal products are there. You're all well-versed when we actually have to get those out. I do want to have a couple of slides here quickly on antibiotic resistance does not confer disinfectant resistance, because I get asked this question all the time. So if you have an E. coli that's producing that carbapenemase enzyme, your disinfectant that kills regular E. coli is going to work fine, because it's different mechanisms. Antibiotics are really like a lock and key, and disinfectants are a lot less elegant. They're like dynamite or sledgehammer. So I did this picture analogy here. So the keys are the antibiotic, the key holes are the organism. So antibiotics work through a mechanism where it has to be perfect to go in and open that lock to kill the organism. And sometimes we see a mutation, right? So the antibiotic we've had around for a while, the organism changes the keyhole on us. And our older antibiotic for the skeleton key there just doesn't work anymore. So we have to come up with a new key to get into the organism because it's changed something. Usually the cell membrane changes or it produces an enzyme. Whereas disinfectants, I've got these pictures here of a zucchini, cantaloupe, pumpkin, honeydew melon, watermelon, and an acorn squash. And what is similar about all of these different looking things? Well, they all have a skin, they all have a pulp, and they all have seeds, right? All the way across the board. They're actually all related genetically in the same family of the Cucurbitaceae. So even though they look that different, they all come from the same family. And Cucurbitaceae sort of reminds me of Enterobacteriaceae. So if I have a disinfectant that works on one member of this family, so I've got a disinfectant that works on watermelons, what do you think it's going to do to a pumpkin, another member of the family? Yeah, it works really well. So if I have a genetic mutation and my watermelon goes from my pink flesh with white seeds, it mutates and all of a sudden I'm getting white flesh with black seeds, or it mutates to watermelon CRE and it's got pink flesh with black seeds, what do you think happens to the disinfectant sledgehammer? You're right, it works fine. So I use this analogy a lot as the infection preventionist for diversity because I get asked this question all the time. Does your disinfectant kill whatever? Or you don't have this organism on your label. And I'm saying, but we can kill 12 other members of that family. So trust me, it's going to take care of it. Now, EPA won't let us say that. We can only put an organism on our label if we actually have tested it. To the microbiology tech in me, I just don't understand that at all. So communication during pandemics, during any kind of an outbreak, during anybody in a panic, you know what it's like to try to discuss some of the misinformation out there with people that just don't want to listen to you. It's worse with facility outbreaks. I always got yelled at. What took you so long to get up to the floor? New organisms show up. I was the most popular person in the hospital. And, the pandemic problems that we're all facing. So what do I try to do? I try to get the facts out. And I use reliable sources. I posted twice in the past 2 days documents from JAMA, New England Journal of Medicine, and CDC, because I want it to come from a reputable source. And I apologize when I post an article from JAMA saying I haven't had time to simplify this. Put on your big boy pants and try to read this, because I should try to bring it down to that grade 6 or grade 8 level, a newspaper level for people to understand. We went through the confusion. This is what we wore during SARS. We had our waterproof gown on, 2 pairs of gloves, N95 respirator goggles with a face shield over top and hair covering, and he's got booties on. We realized that was way over the top for a envelope virus that's spread by coughing. But then you had Ebola show up, and we started wearing much the same kind of thing, which I can't see a lot of the reasoning behind this other than that's what they had in 1976 in parts of Africa as protective equipment. That's all they had. There's really no evidence that any of this makes you, your portal of entry with this is your mouth. Spread the same way as norovirus. Patients don't present with bleeding, they present with vomiting and diarrhea. However, SARS-CoV-2 showed up, and you get these pictures showing up from Korea. You get these pictures showing up from Korea where they're spraying disinfectant on the streets. Please don't do this. It's not necessary, but it looked great. It made people feel like we were doing something. And I find this to be miscommunication for sure. And then we get the WHO coming out saying droplet contact for this new virus. And the CDC comes out saying airborne contact with an N95 respirator if they're available. If they're not available, you can just go back to contact droplet. That caused some confusion to me. Health Canada, where I live, is contact droplet. They do recommend a fit-tested N95 respirator if you were doing aerosol-generating medical procedures. Our list is tiny. It does not include intubation, extubation. So ours is really, really tiny in terms of an aerosol-generating medical procedure. And that we need to get better control of what's going on with all of this. I've already stated that. So you got to get the facts out there. During outbreaks, I always had newsletters coming out, bulletins showing up as many times a day as I could get them out when I got back to my desk. We were very visual visible during outbreaks where we would be up talking to the staff. I tried to get up on the floors at shift change, at report, so that I could sit down saying, okay, this is where we're at with this norovirus outbreak. We're up to this number of people. We put this into place. During SARS, the original, I did all the town hall meetings. So I was meeting with upwards of 300 people at every shift change, bringing them up to date on what was happening in the rest of the world with SARS. We never had a case in Kingston, Ontario. We had lots of scares, and a lot of frightened people. And I kept trying to say, don't get coughed on. So keep calm and don't cough on me. There's a lot of great cartoons that come out that I like looking. There's an IP down in the US that her Facebook page is great because she'll have 30 of these every Friday. Different things that sort of makes me smile. There's always going to be new problems. There's always going to be new bugs. Don't panic. Take a look at what's going on. Find out what your disinfectant does to it or a similar organism. And keep in mind the chain of transmission and horizontal infection control. Remind people that's why you should disinfect this frequently. This is why you do hand hygiene. This is why we have masks. Remind them of the chain of transmission and how that gets in. We're trying to protect them from everything. I hate to say, we ran into an issue with personal protective equipment, both sides of the border. That should never have happened. After H1N1 in 2009, we were all supposed to have a pandemic supply hidden somewhere. And a lot of people stopped doing that because that's really expensive to have it sitting in a warehouse or it expired. So we do provide staff with personal protective equipment to protect them. We fell down on that point for sure. Making sure that we do appropriate use of disinfectants. And I'm going to talk to you a little bit further about this next month on, I think we need to disinfect more than once a day. And we totally forget about patient hand hygiene. Patients have to stop self-inoculating themselves from the environment. Main mode of transmission of C. difficile is fecal oral, and I don't think many of your staff are putting the spores in the patient's mouth. That's another area that I think we need to focus on. These are elevator screens that I got a couple of years ago now that just reminded people there between these two elevator bays was a hand sanitizing station so you could do your hands. I thought it was a great way to remind people. The references that were mentioned through this presentation, and I will share this deck with Tati so she can share it with you as a PDF. The references are all in here if you actually want to read some of these papers. They're rather extensive looking. And some contact information. My email is there. I'm more than happy to answer questions. The solutions design for healthcare.com, the SDFHC /CE. Right now, I'm not sure if we're offering CEU credits for presentations, but there's about 10 presentations of that site, some of which I've referred to here about the spore site everywhere, Candida auris, basic microbiology. And then Diversity Digital is a site that has all kinds of videos that if you take a look at, it talks about how to clean a patient room, how to clean a washroom, how to strip a floor. There's all kinds of really good tools there, and it's all available for free. You don't have to be a customer to get into the site. So, questions? Did anyone type any questions into the panel there?
Jim, thank you so much. This is Trent. I've got a few questions, or I guess maybe one to get started on. So you mentioned with VRE taking more of a horizontal approach and that you guys aren't isolating for that. So my question, and just kind of maybe just a discussion point for kind of horizontal measures, was for surgical screening for MRSA. Are you doing kind of screening everyone and only decolonizing people with MRSA, or are you decolonizing everyone prior to surgery?
Canada right now doesn't do a lot of nasal decolonization. And we also, if we found someone positive with MRSA, we generally do not decolonize them. Now, if they're a longer stay patient, it may be considered. But I worked in a hospital where it's like a long-term acute care hospital. We had one ward where we had people with us that have been there 35 years. A lot of them became colonized, and the decision was just made to use contact precautions within the patient's room. The nasal decolonization, the literature is changing on that constantly to the better, where it's showing good efficacy, especially if you're doing any kind of surgery on the chest, by not having the patient snort microorganisms down, be it regular Staph aureus or MRSA. I think there's some evidence of that. The problem is a lot of the presentations I go to on that are by manufacturers of the product, and I find the information to be skewed, unfortunately, and weighted in one direction. I like to see pros and cons of all this kind of stuff. The VRE, I was told the money we will save by not swabbing and not having contact precautions and having to do that second clean will go into extra EVS technicians, and that didn't happen. They did lie to me. The horizontal aspect of this is fecal waste management for VRE, C. difficile, ESBL, CRE, another whole talk that I do. And I just had to have a chat with somebody as to, they had an uptick in their C. difficile. And I said, well, how do you handle your human waste in a bedpan, in a commode bucket? Do you have a liner bag? Do you have a thermal disinfection machine? Do you macerate your bedpans or just use disposables? And until you can do one of those four, you're going to have ongoing problems with all those bugs I stated. So we had actually brought in liner bags to line our commodes and our bedpans so that the patient defecates or urinates in the bag. It's inside the pan. It is then knotted and put out in regular waste stream so that we're not rinsing bedpans within the patient bathroom, and we don't rinse bedpans in soiled utility rooms. The patient's discharged, the bedpan goes down to central processing. We put that in place to try to limit the spread of feces, which should limit the spread of VRE and C. difficile. Decolonization therapies definitely have a role, and we're getting better and better literature on that for sure.
Great, thank you. That's awesome. So I see another question in the chat here from Janet. She's asking what the procedures are on the AGP list in Canada.
Bronchoscopy, the oscillating ventilation that they do where the patient lies in bed and shakes back and forth. I can't remember what that's called. It's really bizarre to watch when I actually saw it the first time. I think symptomatic patients, if they have a cough and fever, we would then add in, I'm trying to think what the third one was, but there's literally like three things. Now, with our transparency over the border, I think our anesthesiologists are all questioning and wanting to use N95 respirators for intubation. And I'm not sure which of you belong to SHEA, but some doctors were discussing this. Do you do a COVID test on a patient before intubation to know whether or not you need to use an N95 respirator? And I wrote back as an infection preventionist and said, if you consider this an aerosol generating procedure, culture doesn't matter. It's an aerosol generating procedure. You do it with every single surgery. That is the definition of standard precautions. And nobody responded to it. 2 IPs online said, way to go. But really, we've got to watch what we are classifying as aerosol generating procedures that we don't have evidence for. We know an anesthesiologist should have eye and face protection on. Don't get me wrong, to do an intubation. If the patient is febrile, and you need to do the surgery, we don't change that here in Canada up until this point. Now, again, my infection prevention buddies across Canada are now starting to go, wait a minute, why just because of this virus? What if the patient had influenza? Are you not considering that an aerosol generating procedure and you might get influenza, right? Because you're generating viruses. What if they have RSV, parainfluenza? Pick your thing, human metapneumovirus, other coronaviruses. And I notice the shade talk stopped dead because I don't think we want to do this forever. And this is as an infection preventionist, I keep trying to say from a horizontal perspective, if you're considering intubation, extubation to be an aerosol generating procedure, it is, full stop. Don't do a COVID test, find it's negative, and go back to your regular procedures. That doesn't make sense. So try that with your anesthesiology team. I've actually got a physician that shall remain nameless in Europe, but you would all recognize the name, but I don't want to name drop, who indicated to me it is way over the top right now, but now is not the time to have the discussion. I needed to say something to Shay because I'm an infection preventionist with 30 years of experience. I went through the panic of what's happened with SARS, the original. I haven't gone to my dentist yet. And because dentists across Canada and most of the United States are now classifying drilling or any use of any high-speed instrument to be an aerosol generating procedure. And I talked to my daughter-in-law who works at a dental clinic, and I said, so you're telling me that every October through March, everyone in the office is constantly sick with respiratory viruses? She said, no. I said, I know, because they wear a mask and eye protection as routine to do any kind of work on my mouth. Everybody's mouth, right? Christ, I'm old. Sorry, heavens, I'm old enough to remember when the dentist didn't wear gloves, which was scary enough. But now every dentist and chairside assistant and hygienist has a surgical mask on with goggles or shield for every procedure that they've done. And we never saw a real huge uptick in these people in the direct line of fire getting sick. But I've had people say to me, but Jim, you don't know the next patient coming in may then pick up that influenza virus and they might get sick. So we've got to limit that spread. And I'm thinking, if your frontline people leaning within 2 feet of me aren't getting that sick every winter, I don't think it's an aerosol generating procedure because by definition, that's what it is. You would get that sick. So I'm always looking at the science of these things. We've got studies that show that, there are microorganisms liberated. Yeah, that's why you started wearing masks and goggles. And everybody got healthy again. So it's this kind of stuff that goes back and forth that I think I'm getting to the point in my career where I need to step away from all of this because it frustrates me terribly. Off my soapbox.
I think those are great points. And I think we can definitely relate. I think here in the US, we've seen that panic really take hold.
Oh,
for sure.
Well, to the point where you have to reprocess N95 respirators, like, again, it's been criminal that we don't have a good supply of personal protective equipment. To the point of you don't have enough surgical masks, face shields, goggles, that kind of stuff. That, to me, is criminal. That should never have happened anywhere in the resource parts of this world. But I'm now reading the papers that have stated, well, we got rid of our pandemic supply because that's too expensive on the bottom line to carry that as an expense item. And here in Canada, where I sit, we have a warehouse that stored all this stuff. The pandemic supplies all expired. All the N95 respirators that we did have stocked up because that was mandated. All the straps disintegrated because they were all 3 years out of expiry. And I'm thinking, you can't teach people how to rotate stock? Really? None of you guys work at fast food and learn that lesson really quick when you hand somebody a sour milk because you didn't rotate the stock in the fridge? Holy smokes. I just had that discussion with my boss. Do we need to come out as Diversity with a procedure on how to rotate your stock around disinfectants, right? Because even our disinfectant, some of our products have a 3-year shelf life. And I had somebody phone me up and he said, this is before this pandemic. He said, I just found my pandemic supply. All your stuff expired a year ago. Can we still use it? I say, well, now you're talking 4 years because it had a 3-year from when we shipped it. You may just want to use it as a cleaner, not as a disinfectant, because it cleans great. But I can't say it's still going to be effective as a disinfectant because we stopped testing it after 3 years to show the efficacy. So yeah, that aspect of things sort of also did concern me.
Yeah, that's that's very interesting. Yeah, and I think we've definitely seen that here in the U.S. as well. Well, I know we're at time, but does anyone have any last questions here for Jim? All right. Well, Jim, thank you so much, and we are really looking forward to your next topic next month. So thank you
Not a
again.
problem. I'll share this presentation. I'll send it back to Tatiana because I actually have her email handy. But I'll share it as a PDF. If you actually need some of the slides, let me know and I'll send you the PowerPoint. But it's a lot larger presentation. And I'm a little more concerned about if people take some of my slides out of context, whereas with the PDF, if you're having trouble reading them, let me know, and I don't mind sharing that with you at all.
Okay, great. Thank you so much. And yes, Jesse put a good reminder here. Our next meeting for next month will be on October 30th. So we'll hear from Jim again then. All right. Well, thank you everyone for joining.
Thanks very much. We'll talk to you soon.
All right. Bye.
Thanks, Jim.